Good morning. I'm presenting intracameral pressure comparison of a Tonopen-type tonometer using standard latex covers and concave tunable silicone covers. Our financial disclosures include those listed. IP is owned by CATS Tonometer. Technicians typically screen IOP measurements in the clinic using devices other than Goldman. These screenings are often noted to be significantly different than a Goldman IOP measurement, not uncommonly by up to 10 millimeters of mercury. And in the case of our Tonopen-type tonometer, they tend to be lower than Goldman, making it a terrible screening tool. We examined this in our clinic in 46 patients which had IOP measured by a Tonopen by both a technician and a physician teaching the technician, as well as a subsequent Goldman comparison. The physician measured IOP was slightly less than 1 millimeter mercury lower than Goldman, and these are under normal pressures. And the technician measured almost 3 millimeters of mercury lower than Goldman, indicating this error is user dependent. These errors appear to be increased with increasing IOP. The problem stems from the assumptions made in applanation tonometry, which includes Tonopen-type tonometers, and these are based upon the invert-Fick principle of force divided by area equals the pressure on the inside of the eye. The assumptions in this is that the sphere wall is infinitely thin and there is no shear stress that's included in this force. Also, it assumes that there is a constant pressure distribution over the area that is applanated. Finite element analysis of applanation tonometry of the cornea suggests these assumptions are incorrect, creating stress maximums in an annular ring at the periphery of the applanated area, with close to zero stress at the central cornea. This is supported by anterior segment OCT imaging during applanation, demonstrating the annular stromal buckling. By finite element analysis, the use of a corneal conforming surface is predicted to equalize the stress distribution across the applanated area, also supported by anterior segment OCT. This includes maintaining the pressure distribution across the central 1 millimeter of the cornea where the Tonopen sensor is located. So we set out to design a study which would quantify the IOP error of this type of tonometry surface and compare it to transducer intracameral pressure, including varying the radius of curvature or annular central height variation with comparison to standard latex covers and to Goldman applanation tonometry. Unfortunately, cadaver eyes are not useful for intracameral or Goldman comparison with both a Tonopen nor a rebound tonometry. This is due to the corneal edema associated with even fresh cadaver eyes, and any type of dynamic response to the cornea with either of these two modalities creates significant error. Therefore, we utilize a synthetic corneal membrane with artificial tear surface, which was manometrically modulated between 5 and 60 millimeters of mercury. We then externally measured by Goldman Tonopen with a standard cover and a variable height or radius corneal conforming surface. First, we varied the concavity, or decreasing the radius of curvature progressively. We noted that this increased the IOP readings until about 200 microns, where it dropped off rapidly. It appeared that a 100 micron central concavity was the most accurate compared to intracameral pressure. Examining the 100 micron concavity produced a lower but insignificant IOP error to both intracameral pressure and Goldman IOP. The standard latex cover produced a 13 millimeter of mercury lower average IOP measurement compared to intracameral pressure, which was significantly greater at IOPs greater than 30 millimeters of mercury. This study quantifies the extent of common screening IOP measurement error in Tonopen-type tonometers. This leads to a low sensitivity screening test. The study demonstrates a concave silicone cover for a Tonopen-type tonometer may significantly improve IOP accuracy and can be tuned for both racial and species-specific corneal biomechanical differences. The takeaway is don't miss the boat on these patients. Early diagnosis by accurate screening is key in primary open-angle glaucoma and ocular hypertension. IOP remains the only leading indicator in the diagnosis of primary open-angle glaucoma decades in advance of retinal nerve fiber layer loss and visual field changes.